you see a forced eye deviation to the right, most of us would think it's a right-sided lesion. But remember, gaze deviation does not always point to the lesion. The level of the lesion decides the direction. A horizontal gaze is controlled by a distributed network. The frontal eye fields drive the saccades to the contralateral side. The paramedian pontine reticular formation, or the PPRF, is the horizontal gaze center. Abducent nucleus and MLF coordinate the conjugate eye movement. A lesion in the cortex removes the contralateral gaze drive. So the intact hemisphere pushes the eye towards the lesion, but a pontine lesion damages the gaze center itself, so the eye deviates away from the lesion. In stroke cohorts, gaze deviation is common in acute stroke, especially in large vessel strokes. It has localizing value when interpreted correctly. So in a cortical lesion, that is frontal eye field lesion, the eyes deviate towards the lesion or look at the lesion. Example, left MCA stroke, the eye deviate to the left. In a pontine PPRF lesion, the eye deviate away from the lesion or looks away from the lesion. So in left pontine stroke, the eyes deviate to the right. Seizure reverses this rule. In focal seizure, the eye deviate away from the epileptic focus because of the excessive cortical activation and not loss as in stroke. Persistent gaze deviation in acute stroke correlates with large vessel occlusion and a worse prognosis. So at the bedside, always ask this critical question: is the patient awake or comatose? Awake patient and gaze deviation, it's a cortical lesion. Comatose patient and a gaze deviation, it's a brainstem lesion most of the time. So common correlate gaze with motor findings. Eyes with same side weakness, it is cortical. Eyes with opposite side weakness, it is brainstem. In gaze deviation, the cortex pulls towards the lesion and the brainstem pushes away from the lesion.